It is 1:02 Eastern Daylight Time, and we will now begin. Hello, everyone, and welcome to this webinar hosted by the National Collaborating Center for Healthy Public Policy, or NCCHPP, titled, What Can We Learn from Public Health Expenditure Data in Canada from 1975 to 2018? My name is Carleton. I'm an expert scientific advisor with the NCCHPP, and I will be moderating the webinar today. We have the pleasure today of being joined by our invited speaker, Dr. Mehdi Ammi. Dr. Mehdi Ammi is an associate professor in the School of Public Administration and Policy at Carleton University in Ottawa. I want to thank him for accepting our invitation to speak during this webinar. I will be co-facilitating this webinar today with the help of Natalia Botero, a scientific advisor working at the center. We are also joined today by Laila Mahmoudi and Camille Mercier, who are also scientific advisor at the NCCHPP and who will provide technical and logistical support. Before we get started, there are a few technical details I have to go over. First of all, the microphones and cameras of participants are turned off, since there are many people attending this webinar. To address questions to our invited speaker, we will ask you to use the Q&A function, which will also allow you to vote for questions you would like us to prioritize during the discussion period. You can also use the chat function if you want to share comments or resources with all participants. To do this, don't forget to select Send to Everyone, as shown on the right side of the slide. I want also to mention that this webinar is being recorded and that the recording will be made available on the NCCHPP website within the next few days. To begin, I'll just say a few words about the National Collaborating Centers for Public Health, a program of the Public Health Agency of Canada. This program finances 6 national collaborating centers focused on key areas of public health, which are hosted by different organizations across Canada. The NCCHPP, for its part, is hosted by the Institut National de Santé Publique du Québec in Montreal. The mandate of the NCCHPP is to support public health actors in their efforts to develop and promote healthy public policies, financing and funding of public health systems, and more specifically, public health spending, as we will see, has an important role to play in that regard. On the slide, you can see our main active projects. I will give you a few moments to review them. Since the NCCPP is located in Montreal, we wish to acknowledge that we are on an age-old Indigenous territory, a place of meeting and diplomacy between peoples and the site of the signing of the Great Peace Treaty. We thank the Kanien'kehá:ka Nation for their hospitality on this unceded territory. To give all of you an idea of who is attending the webinar with us today, I will just say that we had over 260 registrants. So clearly, there is an interest in the topic. Most of you, as you can see, come from Canada. And we have very good representation from across the country and from different organizations. I'd like to take the opportunity to welcome all of you and to thank you for joining us. When you register, we ask you if your work requires you to have knowledge of public health expenditure. And as you can see, almost 2/3 of you are required to have it. We also ask you how confident you were in your ability to understand public health expenditure. The majority indicated somewhat confident, and almost a fifth responded very confident. We thus have with us today people who are interested and who are knowledgeable about public health expenditure. So the conversation should be very interesting. This slide presents an outline of the webinar, following my introduction to set the context. Dr. Mehdi Ammi will present key findings from his project conducted with colleagues Emmanuel Arpin and Sarah Erlin, which was published in Health Policy in December 2021. This presentation will be followed by a question and discussion period, during which we will ask Dr. Mehdi Ammi to respond to some of the questions you proposed when you registered and to some of the questions you will put forward in the Q&A during the webinar. So please don't hesitate to submit these as they come to mind. By way of context, today's webinar is part of the NCCHPP's work to highlight various elements of Canada's public health infrastructure that enable the core functions of public health systems in Canada. The NCCHPP is participating in this project as a public health knowledge user. The focus is on public health funding, and more specifically, on federal, provincial, and territorial public health expenditures in Canada. Without further ado, I will turn it over to Mehdi to tell us about it. Mehdi, please.
Okay, hi. Thank you, Carleton. I'm just going to share my screen. Okay, so normally all see my screen. I'm just going to set my timer. And thank you for the invitation. Thanks for the NCCHPP for the organization. I see there is a good turnout today, so thank you for attending. I'm Mehdi Ammi. I am an associate professor of health economics and policy with the School of Public Policy and Administration at Carleton, which is in Ottawa. So I'm not at Carleton right now, even though my background pretends I'm on campus. I'm, however, in Ottawa, which is located on the unceded and traditional territory of the Algonquin Nation. So I wish to acknowledge this. And this presentation is really to try to give you an overview of one paper that has been recently published, which Caroline already mentioned. This paper joined with Emmanuel Arpin and Sarah Erlin. It's an open access paper. I really invite you just to access, download, and read the paper after this presentation if you wish to. And before I start the presentation, I have to go. I mean, it's important, but it's not I have to. I wish to go through a round of acknowledgement, and particularly to all the people who have been contributing to this project. So more broadly, this is part of a research agenda about public health expenditure, public health financing, where there is a real need to build capacity actually in Canada. And I know there are not many health economists in Canada. There are even fewer that are just like looking at this question of public health. And as I would just try to make a case in motivation, this is obviously something I believe is extremely important to do. So just thanking all working group members, research assistants, public health knowledge users. So this includes the NCCHPP and in particular Olivier Bellefleur, who has been really, a very consistent and helpful participant in this project. We got also some data from another group who is working on this question, and the data support from CIHI and HX team. So CIHI is the Institute of Health Information. And we are also been lucky in receiving funding from the Canadian Institute of Health Research. The grant number is on the slide, which has helped us support and actually complete this project. And there is more to come. I will just talk about that at the end. But first, this paper in particular, some of the highlight of this paper. And the first thing, just to clarify, this is a seminar from the NCCHPP. However, I feel it's important. There is a frequent confusion between public health expenditure and expenditure from public source. So health expenditure from public source. Here we talk about public health expenditure. So public health, broadly speaking, you have this on the slide there. It's a diagram that comes from the CPHO report, so the Chief of Public Health Office of Canada from 2021, December, so the latest report, which just essentially says the mission of public health is enhance the health of the population, achieve equitable outcome, and protect against health emergency. There are like 5 functions. In Canada, it's six main functions for public health. They are listed there: health promotion, health protection, health surveillance, assessment, disease prevention, and emergency preparedness. So that's what public health is about. And what the report was just trying to highlight is this kind of renewal and a vision for the renewal of public health systems in the future. And what they were in Canada, obviously, this is a Canada report, but what they were highlighting is one of the building blocks that we need for this public health systems to function well is financing, okay? And just to further this motivation, this is part of a Delphi exercise, so a kind of consensus building survey exercise that we've been running and that we are going to submit soon for publication, where we are asking public health leaders, so let's say managers who are in position just to affect the system, what they think are top priorities. And after 3 rounds, we just like not going to go into the gist in the details of it, but the gist of it is after 3 rounds, we'll see this consensus. And what was very clear is, this consensus of extreme importance of the public health budget, like the large majority agreed. And it's even higher than looking at something that is a major concern for public health practitioners. I mean, at least from the one I'm regularly talking to, the commentaries I've been reading, which is essentially being sure that the public health system doesn't become a system focused on communicable disease, and emergency preparedness. There are other functions of public health that need to be protected. So even that is trumped by, okay, we need budgets, public health financing to do what we are to achieve our mission, essentially. That's what the message is. So some background about public health funding or spending. One important feature, so I was not able to find a good translation from what we call parent pauvre in French, which is essentially saying that this is the one that gets the least, but the point is that there is a small share of funding that goes to public health across the board. So in OECD countries, the average is about 2%, so 2.3% in 2019, but about 2%, just you don't need to remember the decimal, that goes in public health. So a really tiny bit when you think about the health system in general. But what has been a cause for concern in different countries, so this is the example of the US, is that this already small share was actually decreasing. So you see that coming from the federal level in the United States. There are some evidence that it's possibly the case in Europe as well. So this paper by Ben Trenchel, possibly I'm going to clarify why in a second. And what is really interesting is that in Canada, we're actually the top spender in terms of allocation of health resources towards public health. And what you see on the slide is like, so when you look at the comparison, 2018 is the last year that has been like validated for international comparison. But if you look at Canada, we can go up to 2020. But the studies use 2018 data as the last year. So I'm just going to talk about 2018 as the last year. So Canada, about 6% of health spending goes to public health, which is 1 percentage point higher than the UK, where it's 5%, and also higher than Italy, 4.6%. So they are like the top spenders there. Again, OECD average 2%. So what we are really trying to understand is, well, how did we get there? How did Canada manage to be, the country that allocates most of its health resource toward public health compared to other industrialized countries? Then there is this question of, okay, that's the first part of the story. The second part of the story is that it looks like there are some difficulties when you try to measure public health expenditure. The left panel there is just talking again about the US, and it's still at the federal level. And what Lader and colleagues there have been doing is they're just trying to see, whether what is reported as public health is public health according to them. And there is some discrepancy between what is officially reported and what they estimate there, with this kind of margin of error. And if you look at Europe, so that was this point of Rachel, and particularly like the first two columns for illustration, if you see there, you see that the country that spends the least on public health is Cyprus, but according to the WHO, but according to Eurostat, which is the European Agency of Statistics, that's going to be the easiest way to describe it, is Greece. And then the top country, according to the WHO, is Romania, and according to Eurostat, is United Kingdom. So we just see that there might be some difficulties in the classification of what public health entails from an expenditure perspective. So again, this is a first project in a broader research agenda. But in this project, what we aim to do was to understand the long-term evolution of public health expenditure. Okay, clearly there is a momentum, because of the COVID pandemic, just that put a zoom in on public health and the importance of public health. And what the CPHO annual report was arguing is essentially like this is this window of opportunity, and we need to better understand the value of public health expenditure just to argue for like more resources in case there is a need for more resources, especially given public health accounts for a small share of the health spending in general. But the first stage there, the first step is really to say, well, what are these expenditure and how are they evolved? And this is what we are doing in this paper. And we ask 3 questions. How has public health spending changed relative to other health spending from public sources over 4 decades? So we look at physicians, drugs, and hospitals everything from public source. Are there differences over the 4 Canadian ages of health spending? So I'm going to explain more what I mean by that. And last, are there differences between public health expenditure reported by the Canadian Health Data Agency, CIHI, the Canadian Institute for Health Information, and the provincial sources? Again, keeping in mind this idea that in other jurisdictions, this difficulty in classification have been raised. Yeah, well. So a little bit of a methodology, what we've been doing, to try to answer these questions to the best of our capacity. The first is we accessed CIHI disaggregated public health spending data. So the NHX team essentially shared with us the data that they have that separates out what they call disease prevention and promotion of health and occupational health. So the PPH category there, it includes community mental health and addiction, which is not something that is always done in international context, but they were not able to tease this out in the data. So they were not able to separate those. Occupational health, same thing. It is not always considered to be part of the main public health functions. For example, if you look at the whole classification of what public health entails. So we decided to be as conservative as possible and to focus only the PPH category. This PPH category is actually the large majority of public health spending in Canada because it accounts for about 90% in 2018. 90% of the public health spending, in 2018. And it falls under the responsibility of provincial and territories. And then I've been trying to come up with a metric that is going to give us kind of an idea, a summarized idea of how trends have been changing over a long period, because that's what we want to do. We have like about 43 years of data, and we really want to have a sense, okay, look at this long period and not like short run evolution. So we just use what is standardly used in financial econometrics, just like indices, like analogous to something that like the consumer price index, if you want. And these spending indices, they are calculated based on per capita expenditure. They have a value of 100 for the base year, which is 1975 in the general analysis. And we use annual expenditure estimate in constant $975. And again, we cover the period from 1975 to 2018, so that's 43 years. The purpose of the indices was just to account for three factors: the differing population size in each jurisdiction, the differing baseline spending level, because we want to focus on the trends, and the role of inflation, because we just want to be real growth and not like nominal growth. And we have 5 indices. We wanted to get a sense of how the public health sector grew compared to other main sector in the Canadian health system that are paid from public purse, so physician and hospital, but also drugs, obviously not whole drugs, because drugs is also covered by insurance, private money or out of pocket. So just the drug portion that is paid by the public purse. We took these 3 because they are the 3 main spendings, when you look at health from public source in Canada. And we also look at this health sector without PPH. We just say, well, let's look at everything that is not public health and see how it grew from the public purse. Again, everything is public funds. So this idea this idea of 4 ages, so it was again saying, okay, 43 years is good because we get this very long view, but in this very long view, like there are different things that can happen. So we just said, to try to keep things as simple as possible, we are going to use the work of particularly Di Matteo and colleagues. So Di Matteo is an economic historian. And what they say, what they have been showing is that there are like 4 main periods of health spending in Canada. First period from 75 to 90, so 1975 to 1990, which is a period of rapid growth. A fiscal retrenchment in the 90s, so 1991 to 1996. A period of renewed spending from 1997 to 2008. And then a period that goes after the Great Recession from 2009 to 2018. So we just separate our 43 years in this 4 period. And we calculate our indices once again using a new base year. So the new base year is the year that starts the period. For example, for the period of fiscal retrenchment, the new base year is 1991. And we look in 1996 and say, okay, what's the index is telling us about the growth in the period of fiscal retrenchment for public health compared to the other sectors. And the last part was this comparison of CIHI data with publicly available provincial government health ministry budgets between 2012 and 2018, because it was just like too many years to look at. Otherwise, 43 years, not something that is reasonably feasible. And there I want to really acknowledge, that contribution of Robert Smith, who was just doing this work of data creation in the frame of another Catalyst grant. So this is a good example of research spillover, trying to be efficient with public research money. And this work has been part of the publication of the NCCHPP with the NCCHPP on the public health systems in Canada. I really invite you to read those because public health systems are actually quite complex. So are really, really helpful, these reports. And also Julie Fizel-Aniel and team for sharing the M3S data that they got from their CGPH publication. So we do this, and then we just say, okay, we are going to estimate a kind of difference between the provincial estimate and CIHI estimate. So the provincial important disclaimer, this is the budget, okay? This is not the expenditure. So this is what has been voted, but this is not what has been spent, which is an important nuance. So the provincial value is represented as a percentage of CIHI estimate. The reason we do that is because we expected that CIHI was going to be higher, because CIHI, when they just compile information that they compile information they receive from different ministries, including the Ministry of Health. And we also tried to include some organizations that had clear public health mandates that were receiving from provincial funding and that are going to be captured by CIHI, but are not going to directly appear in the health budgets from ministries. So this includes Public Health Ontario, INSPQ in Quebec, and BCCDC in British Columbia. Okay, another view of the findings. Okay, I'm not going to go over the results of the paper. Again, I reiterate, it's a little bit of infotainment there, but I reiterate, the paper is open access. So I encourage you just to go and read it. But what I think are three key findings from the paper. The first key finding is that there is overall a substantial growth in long-term public health spending in Canada. Okay, and that came a bit of a surprise for us because we were really not expecting that when we were starting the analysis. That's over 43 years, okay, 1975 to 2018. I didn't put everything on the slide there because there are like the 10 jurisdiction, 10 provinces, plus we have 2 territories. We had to pull together Northwest Territory and Nunavut because before 1999, there were like one entity, plus the federal direct. So that would be way too much for one slide. But I wanted to highlight, the most populous province and the Nova Scotia because it's also a bit different from the rest. What you see on the slide there, I think, what I want to highlight is the blue line. The blue line there is our PPH index. Okay, so you interpret this as a measure of growth over the 43 years, but adjust for inflation, but adjust for different population size, and that adjust from difference in the start year, 1975 across BC, Ontario, Quebec, etc., etc. But what is particularly striking when you look at BC or Ontario is that you see, so the scales are not exactly the same on each graph, just mind that. What is particularly striking is that the growth in public health is really higher than, if you look at orange, the growth in physician spending, in green, the growth in hospital spending, and the gray there is like every other public spending that is not public health when you look at Ontario and at BC, but it's below the growth of drug spending. So drug has been really the area where spending growth has been the largest, far and large, but PPH is, public health is really just behind. And that's what we see in most jurisdictions, except these 2 guys there. So Quebec and Nova Scotia. If you look at Quebec, so it's a bit hard to see because it's just like in the pack there. But if you look at Quebec, you can see that the PPH index is really flat, and not higher than hospitals. About the level of hospitals, not higher than physicians, not higher than the rest of our sector. Almost, I will show you a number after, but almost like nothing really changed over this period. And Nova Scotia, well, you see it has been really flat up to 2005 and then it increased, but at 2010 back, and it's almost like it went not exactly to the initial level, but really low. So that's the story really there is we see a substantial growth pretty much across the board, higher than other health sector except drugs, but not everywhere. In Quebec and Nova Scotia seems to be some of the main exceptions. So then that was over 43 years. Okay? But a lot can happen in 43 years, but that tells us something about how Canada can be the top spender. Allocating the highest share of its health spending to our public health. Now, we look at the last age. I cannot put a table with the 4 against in the paper. Please feel free to look at it. But looking at the last period, post-recession, 2009, 2018. And what I've been doing on this slide is just like trying to make it as visual as possible. In green is when you see that the PPH index is about 10 points higher than the health sector index, so no public health. And in red, it's when it's 10% below. 10 percentage point below. It's arbitrary, it's 10 points, okay? Could take anything, but that's just really help just see part of the story. Well, you see, there's quite some green still. So that means that there are still some places like Ontario where there is an allocation. The growth in public health spending is higher than the growth in other health sector. You can see places like Alberta or PI where it's roughly the same growth. So public health is not really different than the health sector in terms of growth. And then you see places where it's just lower, and there is actually a retrenchment in public health spending. So that's what you see in red, which is below 100. That means that the public health expenditure in real term has gone down. And You can see this in Saskatchewan, but it's even clearer when you look at Quebec and Nova Scotia. So Nova Scotia, what it says is essentially between 2009 and 2018, it has been cut in half in real terms, the public health expenditure, while the rest of the health sector continued to grow, and same story in Quebec. So that's this part of okay, we need some nuance. Overall, it seems like there is a lot of growth, except Quebec and Ontario, but well, you see Quebec and Ontario are still there. Saskatchewan, Yukon might also see this decrease from the 2009 and onward, but the rest, not a lot of difference between the health sector and public health in terms of growth. And the last one, this is one that is like, inviting reflection. This idea of, okay, recall, we just took CIHI. We just said, okay, in the year, let's look at how much is spent in public health as stated by the province. And we just did the ratio. So the percentage there just tells you that there is a lot of differences, between between the province and CIHI. So the closest is Nova Scotia, where it's about 80%. And then you have like larger difference, just like BC, it's about 40%, Ontario, it's about 30%, Quebec, it's about 45-ish. So that's something that says that there is a difference in classification. However, the difference is relatively time invariant. What I want to make clear is that you need to understand it's not like CIHI has a specific data set and they do their stuff on their own, and province have like this other data set and they do their stuff on their own. The province communicate their data to CIHI, their expenditure data to CIHI, and CIHI does the classification work. So this is essentially the same data, but that is classified differently. But I guess the difference is important to keep in mind, but the kind of silver lining is that at least for the period that we looked at, it seems to be relatively stable over time, the difference. So now, can we reconcile these findings? The first thing is what we find is looking at a very long time period, we have a strong growth of public health expenditure in Canada, while what we tend to hear is that the public health system is not receiving enough funds. And I'm just mentioning these two papers because they have been important in this very recent, and they have been important in this field. The first is by Fizalania and colleague on Quebec, and the second is with by Caldwell and colleagues and on Nova Scotia. And they are both published in the Canadian Journal of Public Health. What Fizalania and colleague found is, in a nutshell, a reduction of public health expenditure after 2004 and 2005 in Quebec. And Caldwell, what they found is that in the public health expenditure have been static after 2015 and 16 in Nova Scotia. So they are just telling us, well, something is not good. There may be a slowdown or a decrease in the growth of the public health spending in these provinces. That's also what we find. Okay, this is consistent with our finding. Our finding were really showing that Quebec and Nova Scotia, to a lesser extent Northwest Territory and Nunavut, were really standing apart. So they may be saying that, okay, we are, and they are using the provincial data, to be clear. I forgot to say that. They are using the provincial data, not the national CIHI data. So there is some consistency, even though, so the story about public health system growth, public health expenditure growth declining or being stable is, we see that in Quebec and Nova Scotia as well, but we don't see that in other jurisdictions. This question of classification, okay, that's a very central one. What do we mean when we say public health expenditure? And this may seem an easy question, but it's not at all an easy question. And what I'm trying to show you there is that, there are different standards on how you can classify expenditure as being public health, as being something else. The left column is CIHI, so they're like the two categories I already mentioned, and remember our focus was on the first. This one, I don't know if you can see the cursor there. Then you normally have an international standard, the System of Health Account, okay, which is there to help make comparable across OECD countries the health expenditure. Then you see there are like 6 categories, but are relatively aligned, not fully aligned, but relatively aligned with the public health functions. If you look at Australia, they go down to 12 different categories of what is public health. And if you look at the UK, they have like 5 categories, and this one is really like, they separate, for example, disease detection and immunization, which is part of prevention, and they have information, education, counseling, which can be seen as also somewhere between promotion and primary prevention. But if you have a different framework to classify, you are likely to end up with different results. Okay, that's what I'm trying to communicate. And it's not something that is only happening in Canada. So what we need is to be able to get towards a shared definition of what public health expenditure is, but doing so in a way that can be classified from the data that is currently available, at least if we want to have a sense of the trends. So, well, what can we do with the public health expenditure data currently available? What I think is important is that we don't end up, and especially out of this webinar, and think, well, you know what, this data, we can't do anything with it. I don't think it's true. Again, I'm trying to highlight that this is not a Canadian specific question. This is like a question that applies broadly to public health expenditure. And, well, it's a free translation of this quote from Voltaire. It always looks good to have like an Enlightenment philosopher. The best is the enemy of the good. We just have to say, well, okay, what can we do with the information we have now, which does not prevent from trying to get to like this shared understanding on what public health expenditure is. As I mentioned, as I've been trying to reiterate, this challenge of public health expenditure data is not unique to Canada, and it lies in the categorization and definition of public health. Okay. First, there are some variation in how public health is defined. If you look at the definition from FAC and the definition from BC CDC, it's not going to be exactly the same, and not exactly the same as the definition of the WHO. And then when you look at inside the expenditure, you are going to see this different classification that was like 2 slides ago. Questions are inevitable when you look at broad economic aggregates. This is the case from the GDP. Okay, that's going to happen. They're always going to have question marks, and it's not like one party is correct and the other is incorrect. It's just like it's a latent variable. We don't know it for sure. We just try to approximate it. From the data, from what we found in this little exercise of comparison, comparing within province over time seems reasonable because this measurement error, call it this way, is relatively time invariant, but it seems preferable to avoid interprofessional comparison in level. Okay, say this province is spending that, this province is spending that, compare the two, well, maybe we're not talking exactly about the same thing. But in trend, if they are relatively stable over time in each province, when you look at the trend, it's going to be something that is relatively comparable. And you can also compare in a province between public health and something else. Because we need to make decisions now, okay? I come back to this question of a CPHO report, and that just says, well, there is a window of opportunity, okay? And to make the case for public health, we just need to use the data and the information we have now and continue to work on, perhaps in 2 or 3 years, get something that is more consistent across different classifications. Okay, so This is, again, a research agenda that is ongoing. This paper is done, but there are other papers ongoing. What we are looking at right now is in a paper with Emmanuel, Sarah again, and Antoine Dewanu. We're just looking at the effect and the long-run relationship of public health expenditure in health in Canada. And this is still a work in progress. We are also looking with Olivier Jacques, Alain Noël, and also, again, Emmanuel, at the political and fiscal determinants of public health spending in Canada. We are going to get a draft soon, and this is going to be presented at the conference. So that's what we're already doing, and what we have started to do with another CIHI grant. The number is there. Thank you, CIHI. Just to try to better understand what public health expenditure are actually, and how they compare across contexts. So what is just classified as public health, and whether something, what is public health in one country is not public health in another. So we just are looking at trying to do this mapping of the different items that enter in public health in different provinces, in different Australian states, and in different English cities. And we just try to see if there is an alignment. That's the first stage. And after that, we hope to see, well, can we just build a new data set that is just going to provide some consistency across these different jurisdictions? That's something that we have started a few months ago, still work to come. But we hope really just to contribute to this better understanding of public health systems, and particularly looking at the expenditure and financing side broadly, and to contribute to really understanding the determinants, trends, and effects of public health. So that's references. Hopefully it's relatively exhaustive from the talk. And I'm just going to stop there because my alarm is going to ring. Stop it before it rings. And welcome comments and questions. Thank you.
Thank you, Mehdi. Thank you very much. All this information that you have presented make us very cautious when we talk about public health expenditure, and it was really interesting. Tomorrow, I just want to let you know that we will send you Dr. Ammi slide deck to all the participants. So we will send the slide deck of Dr. Ammi to all the participants tomorrow. So don't worry if you don't receive it today. We will do that tomorrow. Without any further ado, I will give the floor to Mehdi to answer your questions that you sent to the Q&A box. And we will go to Natalia for the first question from participant. Natalia?
Thank you, Caroline. And yes, we have quite a few questions, so I'm going to start. The first one, our participant wants to have some clarification about the numbers used in the presentation. So he's asking, in terms of public health expenditures, is an aggregate of all expenditures from all orders of government or only from one public administration? For example, in the case of Canada, the federal government. In other words, in the case of Canada, do public health expenditures include those made by municipal public health units?
Okay, so what we are seeing is the money that comes from the provincial government, but this money is including the transfer from the federation. And this is also including the money that the province is transferring to the municipality. So that's this kind of mixed bag that falls under the responsibility of the province, but that's not directly, it doesn't need to be necessarily something that has been collected from taxation by the province. So this is, yeah. So I think I see where you're going. We don't have, for example, the municipal spending that is just coming from municipal tax. It's not captured there. And one of the other things that I didn't show you, but that is in the paper, we also look at the federal direct. So, I mean, there are special programs for, institutionalized population, indigenous population, etc. But there it's looking at the provincial level.
Thank you. Natalia, do you have another question?
Yes, I do. I'm gonna go in order first. So how do these findings in Nova Scotia and Quebec align with population health outcomes?
Well, we didn't look at the outcomes. Just to be clear, this is another paper that we are doing looking at the outcome. We're just looking at how much is spent. Okay, we don't say there is enough money or there is too much money. We just say, okay, that's how much is spent. And we don't adjust for the difference in populations beyond the fact that it's a per capita difference. That, you know, in Ontario, there are like 40 million people, and in Quebec, there are 8 million, et cetera, et cetera. So we just don't do that. And so that's going to be the short answer. We have another paper where we're trying to link the outcomes with the spending, but in this paper that I presented today, it's not there.
Thank you. Another question, Natalia?
Yes, I continue. So we also have another question about the numbers. Were numbers adjusted for purchasing power party as in the data below? So Dr. Ammi, there is a link in the Q&A. I don't know if you can click on
I'm just seeing it. Yeah.
Okay, I see. Bank.
Yeah, but I think but this is in Canada. Okay, we cannot, we are not comparing Canada to something else. We're just looking within Canada, different jurisdiction. So there is less a sense of adjusting for purchasing power. We are seeing the difference using the CPI, you know, the price index, but that is just adjusting for inflation. But we don't try to say Canada versus, I don't know, Australia or France there. So that's not something that we necessarily need to do. That would be, what you say is for international comparison, but here we are within Canada, different jurisdiction.
Okay, thank you.
And I'm gonna group these two questions in a two-part series of questions because they're related. So it seems to me that it's possible to have rising expenditures, but still have these expenditures being sufficient. Particularly if you have a view of health promotion that focuses on the importance of investing in social determinants of health with more urgency than growing clinical or medical services. Would you agree with this? Will your work engage with these kinds of questions about relative expenditures? Arguably, social determinants of health investments will be outside of health / public health. That's a whole other expenditure discussion.
Yeah, that's the next question. Essentially, you're right. That's the question about value. The current question is saying what the paper I presented today, is saying is how has public health expenditure grew, but it's not pretending that this growth is justified or not. It's just saying we observe growth, and it's in a way giving us some information about the choice that were made by government in just allocating the health resources toward different utilization. So we don't know if this is enough or if it's too much. And I'm not going to say because Canada is spending the most, that means that we are spending enough, because we don't know the results in the UK, we don't know the results in Romania, we don't know the results in Greece. We just don't do that. That's the follow-up question. And you're right, that's an even more important question. But our view was, let's start to do the first step, understand how these things have changed, and then look at outcomes. So we are looking at outcomes. This is the paper I briefly alluded to in the conclusion. We are looking at avoidable mortality from preventable cause, because we're just trying to find one outcome where we think public health should have a broad effect. And we are also looking at this long-run relationship, because we just are conscious that public health is just going to be a cost now, but outcomes later. So we just want to allow this to happen. I'm not going to say more on that because it's still work in progress, but that's what we are doing. And on your point on social determinants of health, you're right that we don't, this is the way CIHI collect the data. In some jurisdiction, they receive information, let's say, from the Ministry of Education. There's a school vaccination program that is ongoing in education. So it's not exactly social determinant of health, but just saying, well, the money may come from another purse, education or labor or environment. So we don't see this all the time. Our focus is really tightly on the health responsibility. Sometimes there is a little bit else. And the first question is knowing what do we obtain from this public health expenditure that we are able to track from the data and health outcome. And the question after will be, well, how do we know if we need to account for like investment, expenditure in education, expenditure in environment, et cetera, et cetera. Sorry, that was a long answer.
Thank you, Mehdi. Natalia, maybe I could go with the question from a participant that registered. There is the following question, Mehdi. Considering the trends from 1975 to 2018, what do you expect to see in the next few years with regards to public health expenditure?
Yeah, so this is a question about making a guesstimate. You know, it's not a forecasting, it's just based on seeing. And I've been trying to have a quick look about the correlation of spending and public health crisis and see, if, because there is this idea of reactive spending, and but sometimes if you have a crisis, boom, a lot of money is spent in public health, and then the year after falls down. And what I've been seeing, there is just like we see the same kind of story as with SARS and with H1N1, where we have like this kind of small increase, small correlation between the number of cases and the increase in expenditure, not everywhere. And then sometimes it stays at the level, sometimes it goes down. So that's just like for the public health, there may be a sense that's just going to go slightly up, but now the data has been changed, a new classification has been created for COVID spending, and COVID spending has some of the stuff that is public health and some of the other that is not public health. So that's going to be a new challenge to understand. The other thing is looking at, how, when you look at hospital spending, if you remember from the graph, how it was like pretty flat, not super flat, but just growing very slowly. If you think about all this question about, not enough beds in hospitals, the workforce burning out, etc., you can imagine that there is going to be like more going to the hospital in the coming years. And the last part is stagflation. So we don't know what the Central Bank of Canada is just going to lead to, but we have some, we can foresee that, this idea of fiscal retrenchment that happened in the 1990s may happen in the coming years. And if it happens, what is interesting, it looks like that public health has been relatively protected when you compare in the 1990s compared to the other sector. So might be like, I'm just trying to say, okay, but my guesstimate is public health is likely to be protected, especially because of COVID. But you can imagine that's not going to grow a lot, but the hospital is likely to grow more because of all the pre-existing issues that were there, but has been like made like front and center because of the past 2 years. So that's my guesstimate.
Yeah, thank you very much. Natalia, do you have another question from the participants?
We do.
We have a lot. Thank you to all the participants.
And I think, Dr. Ammi, that we had at least 2-3 questions around the same idea of social determinants of health. Okay. So I have, to all of you, I have responded in the chat because I believe this has been answered. If not, just write back to me and we will follow up. So then next question in the chat, do you know approximately how much of the public health budget is immunizations? I have worked in Ontario, Manitoba, and BC. In BC, public health administers the majority of immunizations, including the infant series, which has expanded great over the past 40 years. Could the increase in BC expenditures actually be pretty much attributed to immunization purchase on delivery?
That's a great question. I don't know for sure, because what we observe is, we segregate PPH category. And actually, we've been working closely with CIHI, and recently we've been given access to what they have, the detailed level. So I would likely be able to answer your question in 1 year from now. But at this stage, I cannot say for sure that this is the main driver, but if you have experience and you can say, well, I think that's a contributor, I honestly don't know, because we did not observe that in the data.
Thank you, Mehdi. Natalia, maybe we could go with another question, and then we could go back to a question from the participant that registered. So I'll let you go with another question, please.
Perfect. From the list of countries with public health expenditures, what is the quality of life, and are there the life apologies. From the list of countries with public health expenditures, what is the quality of life, and are the life expectancy the same?
So I think this is the same question about the value, the same kind of idea that you are just looking at spending and we want to know what we get from that. So I'm going to make the same answer. We have not looked into it yet. If you want to know if Canada is doing comparatively better than, because it's the top spender in public health compared to the OECD in general, the answer is no. It's not doing much better. It's the middle of the pack. Okay, so there is, we cannot say that, okay, Canada is spending so much on public health, the highest share, and that's something that we can immediately see in an adjust analysis, just simple comparison, by better life expectancy or better quality of life or better, better quality or whatever you can think of. Middle of the pack, really. That's where Canada is. It's not horrible, but it's not like awesome.
Thank you.
Thank you. And Caroline, I wonder, just sorry to interrupt, I have a voted question. So I wonder if it's worth asking.
Good. Go ahead. Perfect.
So many of the investments that benefit public health occur outside the health sector. For example, investments in education, transportation, environment, etc. How do we account for these investments? Shouldn't they be considered as well when we look at trends in public health spending?
That's a great question, and this goes back to the point I was trying to make about defining public health, which it's because public health is so broad, you can expand the perimeter almost infinitely, and everything is going to have an effect on the health of population, so everything is going to be public health. My view, and this is just my personal view, is that it would be counterproductive to go this road, because then attribution becomes extremely difficult. You cannot say, well, I spent so much on public health and I got whatever outcome, increased life expectancy, less avoidable mortality. That's the first part, attribution issue. Second part is saying, well, we're already seeing that based on how CIHI defines public health, there is a large growth across the board, except in Quebec and Nova Scotia. And as I said, Northwestern Territory and Nunavut, if you look at the paper, you will see there is a jump. Northwestern and Nunavut, you see just flat, jump, and then flat again. So something happened at one point and then didn't move. So I guess I will not, my personal view would be, I think it's not the right way to look at it for now. It's better to keep a focus on public health system in the narrow way when you think about expenditure, because if you start to try to tease out, let's say this expenditure on I don't know, pollution control is just also part of public health, you are going to see that the public health expenditure is just going to grow like crazy. And then the value for money of each public health dollar is going to be mechanically go down. And I don't think this is something that makes sense in my view, but that's just my view.
Thank you, Mehdi. Natalia, I'll let you go with another question.
Okay, good. We have more questions here.
Well, I have one. If you,
sorry?
It's up to you. It's up to you if you have one already.
This is a follow-up from for the first question about the numbers. Thank you for the clarification. Do you have any idea of the portion of the expenditures for public health that does come from municipal taxes?
Yeah, so I will not remember the numbers from the top of my head, but what I can tell you is that this is essentially a story in Ontario where you see that there is like municipal spending, municipal public health spending that is coming from municipal taxes. But there has been a peak somewhere in the mid-2000s, because there has been some change in the agreement between the province and the municipality in the cost sharing. And then it fell down. So it's not big, And what I remember is also seeing that in Manitoba and Saskatchewan, this is something that has been slowly rising. So the contribution of municipalities to public health. I don't remember the proportion, something I can definitely look into, but it's small. That's what I can say. It's small when you compare it to the province contribution, which is really high. And then you have federal direct, which is somewhere, let's say, moderate. Then you have a social worker compensation board for occupational health. And then you have municipal, that is just like very at the bottom, except for Ontario, where again, there has been like this moment where the cost sharing agreement has changed. So that Ontario had to use more of the municipal taxation to increase the public health, to contribute to the public health, enterprise. And then when the cost sharing has been they rolled back essentially from, I don't know, I think it was 75 province, 25% municipality. Then they moved to 50-50, and then they rolled back to 75-25 again. Okay, so that's what I can say.
Thank you. Should I continue, Caroline?
Yeah, go ahead. Yeah, no problem.
So before I move to a new question, Dr. Ammi, I wanted to ask you a follow-up question related to our previous answer. Yeah. This is related to social determinants of health expenditure. So there is a follow-up question. Okay. The participant wants to know if you know of any research or policy papers that look at social determinants of health expenditure. Has there been any work capturing this type of expenditure, especially capturing the expenditures on social determinants of health, which indirectly are public health expenditures? Are provinces decreasing direct public health expenditures, but increasing social determinants of health expenditures and ultimately possibly affecting public health outcomes? Yeah. So if you're aware of any sources, the participant is interested in these resources.
So I don't remember seeing a lot of this kind of crowding out, because what you are talking about is the crowding out essentially. So I remember two things. A paper, I can't remember the name of the first author. I hope it's going to come back to me before the end of today, but it's in Canadian Public Policy. And what they're essentially, it's a journal. So Canadian Public Policy is a journal. What we are looking is at the crowding out of different spending categories between health spending and just like other kind of education, infrastructure, etc. So we're looking at this kind of, it was not specifically about health, it was more about the budget choices. But, education might be, that's part of a social determinant of health. So infrastructure, if you think about, decent housing, decent access to public transit, that's part of a social determinant of health. So that's one. And there is another one. So this one, I remember the first author, Dutton. It's 2018 in the Canadian Medical Association Journal. And there they were comparing social spending, which is broadly defined. This is really a Canadian term, I'm not quite sure. It's family services, for example. And the health spending in general, and they were just looking at mortality and life expectancy. And the point we were making, it's kind of fixed effect model, but the point we were making is that the return on health is higher for social spending compared to health spending in general. So that would be the two. That's the two that come to mind.
Another one, Natalia, on that side?
Yes, I have more.
That's a lot of questions. That's good.
Lots of questions.
Yeah, a lot of questions. That's very good. Thank you very much.
Well, yeah, I anticipate that we may not be able to answer them all, but we'll try. So for the PPH, I was wondering if you could provide a few examples of expenditures, including the PPH index that could be clinical in nature versus health promotion and disease prevention activities, just to get a sense of what might be lumped in there that is understood as public health scope of practice or external to it. And the person clarifies, I completely understand the variability and the complexity of what is included in that category. The definition of public health being so hard to pin down.
So if you think about like screening programs, just like mammograms, that would be something that is public health because it's prevention. and that will be in the PPH category. So that's going to be one example of what could be there. I'm sorry, I forgot the second part of the question.
Natalia.
Sorry, I'm back. Let me just go back to it.
It was a long question.
Yeah, exactly. At the end.
Sometimes it's difficult to remember all, you know.
Oh, I seem to have lost it in the chat. I'm sorry.
Maybe we could go. Maybe we could,
okay, so I think I found it.
Let's move to another one and give me 5 seconds to find it again.
Okay, well, I could go with a very quick question, maybe the indices. What are the advantage of and disadvantage of working with public health expenditure indices instead of dollar value? You know, you are using indices in your study, so.
Yeah, so we've been trying to come up with a way, just providing a message in the simplest possible fashion. And because we're focusing on growth, we're thinking getting indices instead of getting the per capita amount would ease the comparison between the different categories. Because if you look at, for example, in Quebec, 2018, it's about $100, something like that, or $1,000 per capita, and it's 100. It's $100, and it's about 10 or 12 times bigger when you look at physicians, about 15 times bigger when you look at hospitals. Yeah. And then you add that, when looking at the different provinces at the same time, it's a bit hard to wrap one's head around that. So the advantage of using the indices is just to try to simplify this information and get a sense of growth, and we see the growth. We just look at the number and we know what we talk about. The disadvantage, the challenge is that, well, we lose track of how much money is actually spent there. And that might be an important information, especially if you think about, how much exactly is spent and whether this seems small or not. So that would be the kind of balance between the two, but I guess we elected to get to this summarized number that provide the information we want to convey, which is about comparing growth.
Okay, thank you. Andrea, Natalia, sorry, I was looking at the question.
I have found it.
Do you have another question?
Should we move on to another question, or yes, do you want me to quickly go back to? Should we move on? Okay.
We have few more minutes actually.
2 more minutes. So yeah, we won't make it, but let's try. So is it possible to separate out public health crisis spending, for example, in COVID, from other ongoing spending? I'm wondering if we will see a COVID bubble versus a sustained spending. I also wonder if spending on other things like CERB can be captured as part of COVID spending.
Okay, so first part, can we separate public health crisis versus ongoing spending? For the past 2 years, we will be able to do that using CIHI data because they created this COVID category. So that is giving us a sense of what is public health, let's say, steady state, and what is public health crisis period, even though it's focused on COVID. The second part is CRB part of the COVID spending, at least from the CIHI perspective? No, I don't think so. I think the CRB is just going to be this amount of, CRB, this is this kind of financial support that has been provided by the federal government as a kind of relief for individuals whose income has been affected by the crisis because they lost activity or lost job. So it's not part of a COVID support, but that goes back to the question about what is public health. Is like, for example, income support part of public health? I don't know, and I know that the definition we adopt is not this one, and this is not the definition I want to adopt. I prefer to stick with a more narrow definition just to make a case. If the input is the same, if the output is the same, ceteris paribus, you put a higher level, you are just going to obtain less per money. So if you just say, well, income support is part of public health, let's see what happens. my view is that, again, I reiterate, I don't think this is the way to go if we want to promote investing more in public health systems, when what we see is that Canada is already the top spender. I mean, it's wrong to say top spender. The country that allocates the highest share of its health resources to public health, and that it seems that except Quebec and Nova Scotia, there is a large growth across the board. So that's my view.
Thank you, Mehdi. Natalia, we have time maybe for a last question before we close the webinar. So you can go ahead.
Okay, so we have time for one more question. So thank you all. We had so many. This has been so interesting. So what are the factors driving growth in public health, and how do they compare to those for other health spending components?
Yeah, thank you for this question. That's exactly the other paper we're doing. So that's the paper with Olivier and colleagues. So we are doing exactly this exercise but we focus on political determinants, so proximity to election, the ideology of the party, and fiscal determinants. We know whether there is like austerity, rise in debt charge, etc. And because this one is closer to the end, I can say a little bit about it. It's going to be, again, presented at a conference, I forgot where. But we don't see a differential treatment of public health and curative spending. So we just say, let's look at public health. Let's look at curative spending from public source, and we take the big three there, physicians, hospitals, and drugs. And we're really thinking that public health, because it's this quiet policy that is providing results in the long run, there might be less more sensitive, to gaming from politics. We don't see that at all. And we were thinking that, especially because it's a descriptive paper, but the Bernd-Redshell paper I mentioned at the beginning of the presentation in health policy, we're really saying that in Europe, because of austerity, public health has been cut very hardly. We don't see that in Canada. When there is austerity, both public health and curative spending go down, but public health spending go down at a lower rate than curative spending. The thing that we note that is interesting, that speaks to this idea of crowding out, is that if you say you have a health budget that is fixed, in this health budget, you can allocate part to public health, part to curative, and you look how much was committed to curative care in the previous year, this is going to limit the growth of public health in the next year. So essentially, the key determinant there of public health growth, it's not like so much, it's not differentially politics or austerity. It is whether a lot of money was already, whether a higher share of the health budget was already committed to curative care in the year before. So that just speaks to the idea of potential crowd out of curative care versus public health. All right.
So it's about time. We are already done what we had to do. Thank you very much for all the participants. I will share my screen to go to my last slide.
Thank you for the questions. That was great to have this engagement.
So thank you to all of you. In conclusion, I wish first and foremost to thank all of you for your participation, and a special thanks to our invited speaker, Dr. Mehdi Ammi. For those interested in this topic, I invite you to read the article we talked about. For our part, at the NCCHPP, we are hosting webinars on different aspects of public health and of public health systems in Canada. So I invite you to subscribe to our e-bulletin to stay informed of future activities. We will be sending you a link to a short evaluation for this webinar. So please take the time to respond, because we really do use your feedback to inform our work. So thank Mehdi, thank Natalia, thank Camille, thank Laila, thank all the participants, and have a good day. Bye-bye.